Hi everyone. Here is the thing. Prostatitis is not just an old man problem. If you are 80 years to 40 years and have a deep pelvic pain, burning urine, pain during ejaculation or after ejaculation, or a dull ache that just won't quit, you are not imagining it. Modern data shows prostatitis type symptoms hit young adults too, and it is very common enough to matter. A recent study has shown that prevalence in men around 4.5 to 9%, with plenty of cases in younger patient populations. Now, the prostatitis is an umbrella term. So, as a urologist, we generally categorize in four main categories: acute bacterial prostatitis, sudden fever, severe pain, urgent care; chronic bacterial prostatitis, the recurrent infections and cultures are always positive. The third one is we call it chronic pelvic pain syndromes or chronic prostatitis, which is the most common variant. Often no bacteria is recognized in this. And the fourth one is asymptomatic inflammatory prostatitis, which is found incidentally and one of the few rarest of the thing. In real life, most men who say, I think I have prostatitis, actually lands in type 3 category, that is chronic pelvic pain and chronic prostatitis complex. With urinary and sexual symptoms and with a bad quality of life. Latest AU guideline treat it as a multifactorial pain conditions and not just infections. So why young men get it? What does this really mean? Causes are mixed. In men under 35 years of age, sexually transmitted infections like chlamydia or gonorrhea must be considered, especially with urethral discharge or high-risk exposure. Don't guess, you have to get yourself tested. But that is not the whole story. Many cases are non-infectious also. Pelvic floor muscle spasm, nerves, hypersensitivity, prior gut or urinary tract infections, stress, or central pain amplifications conditions, even microbiome shift in the genitourinary tract. The newest guideline and the reviews emphasize this biopsychosocial model of the chronic prostatitis. Now, if I talk about the symptom checklist, the typical clues are like deep ache in the perineum, tip of the penis pain, pain with or during or after ejaculation, frequency or the urgency of urine with weak stream, and low backache or lower abdominal pain. If you have fever, rigors, any episode of urinary retentions or feel or systematically ill, this could require urgent care. How do we diagnose? So the good care start with the history and examination, urine test, and of course in some of the patients, sexually transmitted infections, investigations related protocol. For chronic pain, we use the NIH Chronic Prostatitis Symptom Index, NIH CPSI, to track pain, urinary bothers, or the quality of life over time. It is a validated and still the standard outcome tool in the clinical trials as well as trials. Culture or the old 4-glass tests are reserved. They are rarely used now and rarely changes the management protocol. So what actually helps? Now coming on to the evidence-based plan. Here's the plan I give to my patients aligned with the 2025 AUA and 2024 EAU guidelines. Don't shotgun antibiotic for a month if there is no proven infection. Overuse is not helpful and has its own risk. US data shows antibiotic prescribing for chronic prostatitis or chronic pelvic pain syndromes is falling, which is a good stewardship. Test first, treat positive appropriately. Target short trials can help in selected pain. Alpha blockers trial if voiding symptoms persist for more than 4 to 6 weeks. NSAIDs short term for flare-ups like fever or sudden excruciating pain. And we do consider neuromodulatory therapy like low-dose TCA or SNRIs or gabapentinoids when neuropathic features dominate, especially specialist-guided is required. Pelvic floor physical therapy, which includes myofascial release, down training, biofeedback is a cornerstone, which when muscles are tight or tender. Add gentle mobility work, avoid pain-provoking heavy cycling or prolonged sitting during flare-up. Lifestyle and mind-body changes include sleep, anti-inflammatory diet pattern, graded activities, and stress reduction. Psychological comorbidity is common. Treating it reduces the pain intensity. Now coming on to the sexual health part of the chronic pelvic pain syndromes. It is linked with the sexual dysfunctions. Addresses openly. A 2025 meta-analysis estimated that 59% experience some sexual dysfunctions, thereby treating pain in the pelvic floor issues really help in those kind of patients. For acute bacterial prostatitis, this is different. Urgent antibiotic is required, hydration is required, pain control is required, and sometimes admissions if severe. Follow cultures and reassess if not improving. Now, let's talk about what are the red flags and when to seek help. Fever, severe chills, urinary retentions, blood in urine, new neurological deficit, or testicular swelling needs prompt evaluations. Chronic pain with weight loss or abnormal examinations warrants complete urological review. Now, the bottom line is young men do get prostatitis like syndromes, and most of the cases are not just infection. So, this is the most important myth. Get tested, track your symptoms using NIH, CPSI, and build a multimodal plan you can actually live with. Subscribe for a full breakdown of the pelvic floor technique and a symptom tracker download next week. Thanks.